twin transfusion syndrome with fetal anemia. I believe we remember quinterior staging from 1 to 5. But one of the important criticisms of the quinterior staging is that it does not represent a chronological order of deterioration. For example, stage 1 can become stage 4 or stage 5 without passing stage 2 and 3. And we shall see this in this video. This patient was a 22-year-old gravida 2 who presented at 5 months gestation for booking and was found to have a monochorionic diamniotic twin pregnancy. The upper twin had died at presentation. There was discordant but normal amniotic fluid volume. The gestational age by ultrasound was 20 weeks, 1 day. She was found to have elevated blood pressure of 200-160 millimeters of mercury. Her first pregnancy was also a set of twins, a male and female, who were stillborn. So we shall see the video. The amniotic fluid of the donor was 2.7, while the recipient was 7.1. So there was no oligohydramnios or polyhydramnios, but there was discordant amniotic fluid volume. So let's look at the video. So the dead twin, the upper twin, with the twin membrane, the surviving twin, not the discordant amniotic fluid between the recipient and the donor twin, not the monochorionic plus, not the chorionicity, monochorionic, diamniotic. One of the things I was not comfortable with during this ultrasound was that the surviving fetus appears to be hyperactive. Could that suggest some form of distress? Monochorionic, diamniotic, key sign of the intertwin membrane. The death of this baby happened probably shortly before the scan or thereabouts. As you can see, the intra-abdominal and intra-thoracic organs clearly seen, including the brain tissues. So we can see the surviving twin and the dead twin in a monochorionic diamniotic pregnancy. So let's remember that when one monochorionic twin dies, the surviving twin may lose part of its circulating blood volume to the dead twin. That will lead to severe hypertension in the survival. And this could lead to hyperperfusion of the brain and other organs. And that is why it's important to do a middle cerebral artery Doppler to check for the peak systolic velocity. So in this case, this is a middle cerebral artery. Look at the peak systolic velocity, 40.39 centimeter per second. And as a rule of thumb, if the peak systolic velocity is greater than twice the gestational age, the chances are high that the mom is greater than 1.5, and that would suggest fetal anemia. So this patient was 20 weeks. The peak systolic velocity is 40.29. So the possibility is that there is fetal anemia. Of course, this is subjective, but we have other objective tools to assess that. And one of them is the Freedom Medicine Foundation calculator. Here we imputed the gestational age. You can see it's 20 weeks, 1 day. Look at the mid-cerebral artery Doppler we imputed, and look at the calculated fetal hemoglobin, 3.9. So mid-cerebral artery peak velocity, look at greater than the 95th centile. Fetal hemoglobin below the hydro zone. Again, using another objective assessment, this perinatology.com calculator, we entered the gestational age, remember 20 weeks, 1 day, and this was the peak systolic velocity. And we calculated the moms, and look at what it says. The median peak systolic velocity for this age is 25.6, and what we have is 1.5 multiples of the median. So fetal anemia. Now, the following day, I decided to rescan the patient and assess some other parameters since there are features of fetal anemia. So this is the ductus venosus. Here is a hepatic vein. So look at the gauge size, should be small. So you can see the aliasing. That makes it very easy to detect or to locate the ductus venosus. Now, while trying to get the mid-cerebral artery here, I observed this slight skull edema, and that made me suspicious. So I decided to go further and have a closer look here. And what did I find? This probably is an early onset of hydrops, consequence of heart failure. So this is a spectral Doppler of the ductus venosus, and the posterity index here is 0.84, and from the chart I use, the 95th centile is 0.751. So this is greater than the 95th centile. Look at the umbilical artery. In one portion, absent end diastolic flow. In another, reverse end diastolic flow. The teaching is to use the one with the least resistance, which is this. But for the purpose of this patient, I would rather use this for clinical practice rather than use this. So now, at 20 weeks, 2 days, look at the umbilical artery PI, the middle cerebral artery PI, and look at the findings. Umbilical artery greater than 95th centile, middle cerebral artery less than 5th centile, same placenta ratio less than the 5th centile. So if we look at this, what I coin as the vital signs of the fetus, everything has gone haywire. No green light, no yellow light. Everything is red. Umbilical artery greater than the 5th centile. MCA PSV greater than 1.5 mom. MCA PI less than 5th centile. CPR less than 5th centile. DVPI greater than. So everything has gone haywire. So I couldn't wait longer. I decided to repeat the scan 48 hours after, based on this disturbing trend. So what did I find? Look at this. There's increase in the skull edema. As we shall see, there was also ascites. So hydrops has developed as a consequence of heart failure. So what else can we see here? Look at the skull edema. So Why is the fetal heart? No fetal heartbeat. 48 hours after the last scan, when these measurements were taken. So, no cardiac activity in the recipient twin. And not the reduction in amniotic fluid in the donor twin compared with the initial ultrasound image. So, thank you very much for listening.